In 1995, I signed up for a college internship in the housing unit at Greater Boston Legal Services. And over the course of 9 months, had the opportunity to have dozens of conversations with low-income families in Boston who would always come in presenting with a housing issue, but there was always an underlying health issue. So my first client was about to be evicted because he hadn't paid his rent, but of course he hadn't paid his rent because he was paying for his HIV medication and couldn't afford to pay for both. Or we would have mothers who would come in whose children would wake up every morning covered in cockroaches, but they of course had asthma, and this would make them sicker each day. And over the course of this time, I grew frustrated with feeling that we were intervening so far downstream in the lives of these families. And in June of 1995, I read an article in the Boston Globe magazine about Dr. Barry Zuckerman, who was chair of pediatrics of Boston City Hospital. And with his blessing, spent about 6 months wandering the halls of this hospital, talking with physicians and nurses who over and over again shared the same story, one that we've now heard hundreds of times since. They said, every day I have patients who come into the clinic and the child has an ear infection, but I know that the real issue is that this child is living in a car. I know that the real issue is that there is no food at home, and I don't ask about those issues because there's nothing I can do. I have 13 minutes with each patient. Patients are piling up in the clinic waiting room. I wasn't trained to deal with this in med school, and I have nowhere to turn for help. Now, it seems that it shouldn't be so difficult to design a doctor's visit or a healthcare system, for that matter, around what people actually need in order to be healthy. But since then, I've had hundreds, probably thousands of conversations with physicians and nurses, health systems executives and insurance executives who say that when it comes to their patients' most basic resource needs, they practice a don't ask, don't tell policy. But there I was in 1995 with physicians confiding in me that it felt intolerable to ignore the realities of their patients' lives, however complex they were, but that's what they did every single day. And I noticed that a number of them had a book on their shelves called White Coat, Clenched Fist: The Political Education of an American Physician. And this book is Fitzhugh Mullins' story of his radicalization when, as a medical student in the 1960s, he enlisted with something called the Medical Committee for Human Rights to provide medical care to civil rights workers in the American South. I became fixated with his story and started digging and digging, ultimately writing my senior thesis on the role of physicians in the American civil rights movement. There were no books on this topic at the time, and so instead I started chasing the physicians themselves: Alvin Poussaint, Walter Lear, Trudy Orris. And there would always be this magical moment in our conversations where they would reach into the bottom drawer of their filing cabinet, pull out a thin manila envelope, and produce for me the field notes that they had taken while down in the South during the 1960s. But it was really only bits and pieces. And in December of 1996, I was at a conference called Give 'em Health, A History of the American Health Left. When I was in the buffet line at breakfast, I remember very distinctly that I was standing in front of the scrambled eggs. When the guy behind me in line said, kind of asked, like, what are you doing here? And I explained to him, and he said, oh, the Medical Committee on Human Rights. I have all of their materials in my attic. So after a very long and awkward conversation with my parents about why I wanted to spend winter break of my senior year in some man's attic in Philadelphia, I succeeded in persuading them and did just that. And he had box after box of materials documenting the role of physicians and the birth of community health in this country. The short version is that the Medical Committee for Human Rights enlisted physicians and med students to come to the South for what they thought was actually just simple work of treating the aches and pains of civil rights workers. They thought it would be sunstroke or blisters, but instead they encountered just devastating violence, including 35 shootings, 65 incidents of arson or bombings, 80 beatings, 1,000 arrests, and 6 murders in the summer of 1964 alone. And the doctors didn't just get thrust into extreme violence, they also accompanied African American civil rights workers and local folks to segregated clinics that in reality offer no health care at all. Clear that the healthcare system in the South was irrevocably broken, they set out to create an alternative. And in 1996, I sat with Dr. Jack Geiger as he talked me through his training at Boston City Hospital, his deployment to the South via MCHR, and the birth of this country's first community health center in Mound Bayou, Mississippi. Dr. Ghali Geiger and his colleagues worked to deliver health care against forces of overwhelming poverty. Neonatal care at the time literally entailed putting newborn babies in Coca-Cola boxes that were filled with hot bricks wrapped in cloth. And I actually recently dug up my notes from that original conversation with Dr. Geiger. He said the project sought to use the delivery of health services as a point of entry for introducing broader changes in the physical and social milieu that contributes to the cycle of ill health and poverty. And though it took a while, Dr. Geiger's message has finally gained some staying power. It's now widely recognized here that just a small proportion of health outcomes are attributable to medical care, whereas the vast majority of health outcomes, of course, are tied to social and environmental factors and the behaviors associated with them. Basically, everything that happens in the lives of people and patients when they're not in the four walls of the clinic or the hospital. And Health Leads was really born of these conversations that I had with physicians at Boston City Hospital in 1995, and this basic understanding of what actually drives health. For 20 years, Health Leads has connected tens of thousands of patients with the basic resources they need to be healthy: food, heat, electricity, housing. And for the past several years has equipped thousands of health systems across the country with the tools that they need to do this: screening, workflows, training, analytics, and technology to address the realities of their patients' lives. We know these connections work. A Mass General Hospital study that was published in JAMA Internal Medicine about a year ago affirmed that addressing patients' unmet social needs, in that case through Health Leads, is associated with clinically meaningful improvements in patients' LDL-C cholesterol and blood pressure levels, the latter actually at the equivalency of introducing a new drug into the patient's regimen. But then in 2010, I got an email that changed my life. It was from Dr. Geiger, who, having learned of Health Leads' work 14 years after our initial conversation, wrote me, and here's what he said. He said, "I thought you might be interested of an historical precedent dating back more than 45 years, when I and other physicians at the nation's first community health center in deeply impoverished rural Bolivar County in the Mississippi Delta literally wrote prescriptions for food. So much meat, so much milk, so much vegetables, so much fruit, etc., for malnourished children and their siblings to be filled at a local grocery store, which sent the bill to the health center, which paid for them out of its pharmacy budget. Our funders in Washington sent someone down to Mississippi to scream at me that a pharmacy in a community health center was for drugs for the treatment of disease. I replied that the last time that I checked my textbooks, the specific therapy for malnutrition was food, and he shut up and went back to Washington. Now, I knew when I got this email that I should be proud to be part of this history, that was what Dr. Geiger intended, but I wasn't. I was devastated. Here, Health Leads was called innovative, a genius idea for doing something that Dr. Geiger had invented decades before, which begs the question of why don't we do what we know we need to do to deliver health in this country? This question has been my obsession for 20 years, and it's actually why I left Health Leads in December to chase the next phase of the work, focused on how we shift the discourse, politics, and policymaking on the belief that we may be bitterly divided as a country when it comes to health care, but we might well be united on health. We all know that the U.S. spends more on health care and gets worse health outcomes than any other OECD country. But while we may spend more on health care, we don't necessarily spend more on health. The sum total of healthcare and social spend across these countries is more or less the same. It's just that our ratio in the US is inverted, with 2/3 spent on healthcare and just 1/3 spent on social care instead of the other way around. We focus on the wrong thing when it comes to our budgets and our policies, but also when it comes to our patients. We had a patient come into one of our partner clinics in Baltimore presenting losing weight. The docs are huddled up about to prescribe metabolic panels and run some blood tests when one of our advocates wondered if the patient might be hungry. It turns out he had recently lost his housing and didn't have enough money to buy food for weeks. He was so relieved, he said, that someone finally asked him. This story plays out 1,000 times every day in our healthcare system in this country, but we still so often ask the wrong questions. Somehow we've designed a healthcare system where asking a patient, "Are you hungry?" is so far outside the bounds of what counts as healthcare that we forget or fail to ask the question altogether. A country where our Centers for Medicare and Medicaid Services, the largest purchaser of healthcare in the world, has launched a $175 million pilot that stratifies hungry patients into an intervention or no intervention control group. That means some get food and some get information about food, with the ethical justification that doing nothing for hungry patients in this country is standard and usual care. Which brings me back to Dr. Geiger. So here's the epilogue to the story. On June 17, 2014, I received a letter from the Delta Health Center, the one that Geiger created. And this is what it said. "You dared to ask the question Dr. Geiger asked 50 years ago. What does it take to stay healthy, not just to get healthy? Imagine if that question had been answered 50 years ago, where our healthcare system would be today. Nothing would please Dr. Geiger more than to have you answer that question on the site where community health centers began in Mound Bayou, Mississippi." So super stressful, right? Explain why nothing has changed in the American healthcare system for 50 years. But it was like this invitation to the mothership. And so I packed up my 3-month-old and my husband, and we drove deep into the Mississippi Delta. And we sat around card tables in the clinic waiting room, listening to Dr. Geiger and his colleagues talk about what had happened. At last, I understood why knowing what to do wasn't enough. While Dr. Geiger wrote prescriptions for food, just the basics of the work entailed unimaginable risk. They tracked down fleets of cars marked U.S. government for community health workers, so they were less likely to be car bombed. And all I kept thinking as I listened to Dr. Geiger and others was that when we say the work of healthcare transformation is hard, we mean that it is intellectually challenging and at times operationally frustrating. We do not, however, mean that it's life-threatening, because Dr. Geiger and his colleagues did that for us. We're in the midst of an unprecedented moment of fluidity in healthcare in this country, but we're also part of the arc of history, choosing every day whether that arc will bend closer or further from a more just, equitable, and rational healthcare system. And I am always left wondering, how do we ensure that in another 50 years, this room won't be filled with yet another group of thoughtful, passionate folks just like us asking that question? What if the question of what it takes to stay healthy, not just get healthy, had been answered 50 years ago? Thank you.